Am I audible and clear?
Very precise, sir. Yes.
Perfect, perfect. So the topic given to me by Dr. Natesh is about do's and don'ts of uh, these newer medication like Mounjaro, Ozempic. I'm directly taking the brand names because they are now known as their own products, and people know them by the brands more than their molecule, like any other medicine. So Ozempic, the semaglutide, and Mounjaro, the Tirzepatide. So I'll just go back to a short, quick history about obesity per se. How when I started the practice somewhere in 2008, a bit before that, and at that point of time, what the scenario was and what the scenario now. At that time, obesity was or weight gain was taken more as a lifestyle disorder or something secondary to only the lifestyle. But at that time also we the doctors were very clear that obesity is not merely a lifestyle disorder. And I used to use that phrase at even at that point of time, and I'm sure Dr. Natesh would agree with me, and the other eminent speakers on this dais will also agree with me that we were we at that point of time in 2008 and even before that, we used to say that obesity is a disease in itself, and obesity is actually a chronic remitting relapsing disease. When I say remitting relapsing disease, means somebody tries to lose weight, he loses weight, but again it comes back because weight is a dynamic process. And we have always been struggling, to make that input from the medical side on how to manage the weight or the obesity or being overweight in the population. Whatever the medications which were available at that point of time, I'm talking about 20 years back or so, were more either the appetite suppression, or we were using the medicines off labelly to give the medical intervention of the weight management, which even Dr. Natesh has mentioned the medications in his presentation. And then came the medications like liraglutide, means the Victoza. I'm using the brand name very freely, and but I'm not endorsing anything over here. Though I'm just it's a disclaimer from my side, which was not approved for the weight management in non-diabetic people, but gave us a very good hope and very good results in the diabetic overweight people. And with the liraglutide, before that, exenatide was there, then liraglutide, and then things were just moving around this one molecule of liraglutide, but restricted to the diabetic obese people. We as doctors have used the molecule very judiciously under supervision, even for the non-diabetic overweight and obese people with fairly good results. And then in 2020, we all know, the medical world got this molecule, the semaglutide. Ozempic came in, but then the COVID era was there, 2020, 2021. So not very widely used globally, though in the US they were used. And then came the 2020, the Tirzepatide, the Mounjaro. And that's how the whole story started. With the Ozempic and Mounjaro, semaglutide and Tirzepatide, there was a new hope in the people to lose weight by using these medications. Are not very difficult to use because once a week injection, the people were very comfortable taking it, though not very easily available to the general public, the general population. It took a lot of time from 2020. It took almost Ozempic in India launched now somewhere around 1 month back, officially launched in India about 1 month back, but was available otherwise in the gray without the proper channel. And Monjaro took almost about 3 years. 2022 it was launched, and then it came. launched in India. I'm just talking about the India. So the 2022 Mounjaro came, and but it launched in India somewhere in the first quarter of this year. So it really took a lot of time for these medicines to come to India officially. But before that itself, before these medicines come to India, like came to India, these medicines really made a lot of waves in the Indian public, in the Indian media, and most importantly, the social media. Celebrities were using it. A lot of celebrities were even endorsing it. There were all the articles all around the country. Social media was flooded with it. Instagram reels were being made. YouTube was flooded with it. Like a miracle has come, and people were just using them and buying them. First is buying them from whatever sources they could with the pricing maybe 5 times or 10 times of the real price, but they were ready to take all that pinch of salt and do for their weight management, and indeed people were getting the results. And finally, then the good news, and the people and these medicines got launched in India. Now I come to the so this is the whole thing which what happened between the launch of these medicines in the Western world, and then took about 5 and 3 years to come to our country, India. Now these medicines are available in India, and the doctors are writing it. But with increasing prescriptions, increasing use of the medication, making the medication available, making the people more aware, I will not say knowledgeable, but aware about the medication, also comes the responsibility of guiding the people on the do's and don'ts of these medication. And here comes my topic. So uh, so I will just put them in a single group, like the weight loss, or I will just use it like I will use this layman phrase of weight loss injections, Ozempic and Monjaro, and I'm keeping that diabetes part out of it right now at this current point of time, to make it a bit easier. Okay. Now, for these two, for these medications, one thing, what is the most important thing as doctors? Now, there are two things. There are three, actually, there are three parties. Party number one is the individual, the patient, or any person who is using these injections. Party number two is the doctor who is prescribing it. The party number three is the retailer, the pharmacy who is dispensing this medication. So let's understand the responsibilities and do's and don'ts of all the three parties. So first, I will come to the responsibility of the doctor. So when a doctor is prescribing Ozempic or Monjaro, what a doctor should ideally see in the patient. So question number one, the doctor has to ask to himself or herself: is the patient eligible for these medication like any other medicines? Is it justified to write or to prescribe Monjaro and Ozempic to a particular patient? The answer is very clear, and I'm again restricting myself to non-diabetic, obese people or overweight people. So if a patient is overweight, let's keep it very simple. If the patient is overweight, patient is eligible for the prescription of Ozempic or Monjaro. Then comes the question, what doctor has to ask: whether the patient is fit to take these injection. Are there any contraindication in that patient, whether to whether to really give these prescribe these injections like Monjaro or Ozempic? And for that, the doctor has to perform these clinical evaluation and the lab evaluation. And in that, the most important comes are the serum amylase and lipase. So the pancreatic enzymes is something what doctor has to every doctor has to see before prescribing Monjaro or Ozempic. And if the amylase lipase are high, then that patient at that particular point of time is not fit for Ozempic or Monjaro. Then comes uh, any history of gallstones which is not being treated surgically. Those candidates should also be ideally should not be kept under the basket of the prescription of Monjaro and Ozempic. Then if there is a history of any malignancy, and here I will not restrict to only thyroid malignancy, any malignant history, should we should be very careful. And in current point of time, I would rather say that we should stay away from prescribing Mounjaro and Ozempic, because we don't have much of the data about the safety of these injections in this group of patients, and we have to wait for few more years to see to have those data collated and then have the final inference of that. Other than that, the people who are not motivated enough to follow the dietary restrictions, what the doctor tell them, those people should not be given Monjaro and Ozempic. And in that, very important is the patient should not be consuming alcohol during or even after the regime of Mounjaro and Ozempic is over. When this question comes, and a lot of people ask whether we can take the alcohol after we reach to our target weight loss or something, then the answer should be, once you have stopped alcohol, it is better to stop alcohol forever. Why to reintroduce it back? And then why the people should be away from alcohol while being on Monjaro, while being on these injection Monjaro and Ozempic? The answer is very clear. Very clear. It's not only about Mounjaro and Ozempic, it's about any modality of weight management anybody is doing. At that particular point of time, we have to understand that there is a lot of load during this whole process of weight management on the pancreas itself and on liver and on kidneys. And then at that point of time, we don't want to add up any extra burden or any extra insult to these organs. And for that, it is very, very important then that the doctor tells the patient to stay away from any sort of addictions, including smoking and alcohol. You can always ask your patient to choose between the two, either these injections or alcohol. And actually, now Monjaro and Ozempic, these drugs are going to be tested for even making people to withdraw alcohol. So they will very soon get the approval for assistance in alcohol or smoking cessation, and that would be something very good. So these are the things. And then what further needs to be done by the doctor is the ultrasound of the abdomen pelvis to see the status of the pancreas. Is the pancreas inflamed, or is too much of fatty infiltration in the pancreas, or and the gallbladder? If there is a gallstone or if there is any sludge in the gallbladder, we should be very careful while prescribing these medication. And out of, like, I have witnessed one patient who had the like, who had developed actually the biliary stasis and then a huge gallbladder, gangrenous gallbladder, which had to be removed actually. Then the cholecystectomy had to be done. So we have to be very clear about that before starting these medications, the gallbladder should be hale and hearty, not having any gallstone or any sludge in that. Other than that, we need to do the ultrasound of the thyroid, and because there is a lot of talk about it, the medullary carcinoma of thyroid, family history of medullary carcinoma thyroid. Not many people even know about whether they have any such family history. So we have to be careful and do that. And if there is any nodule in the thyroid which is hypoechoic and which is more than 1 centimeter, it is always better that we should stay away from prescribing these medications till we have clear data and literature about the safety of Ozempic, Mounjaro in such patients. In any way, any patient who is presenting with hypoechoic nodule in the thyroid gland, which is more than 1 centimeter, we have to evaluate it further for any malignancy otherwise also. Other than that, because there has been a lot of hue and cry in the population about the retinopathy caused by these medications, which still have to be proven, which still have to be proved. But yes, to be on the safer side, it is better to get the eye checkup of the patient done, because in diabetic people, in any way, the annual eye checkups are done, and so we have a document of whether there is a pre-existing retinopathy or not. But in non-diabetic people, usually they don't do their eye checkup very regularly, so better to ask them to get their eye checkup done and to document it. Then the question is whether in retinopathy, whether we should give these medications or not. Answer is not very, very clear. But once there is a retinopathy, I don't see any harm or anything worse going on. If retinopathy is already there, by giving these medications, if we can help the patient otherwise in losing weight. So these are the prerequisites what need to be done. Along with that, if if because if there is not too much of test and investigations happening, is not too much of burden to the patient, then we should do a sleep study to rule out the OSA, the obstructive sleep apnea. In any way, every overweight individual should do the sleep study. And if there is sleep apnea, definitely CPAP should be advised along with these medications. And one more, and the good news is that Tirzepatide, Mounjaro, has already been approved to be used in the patients of obstructive sleep apnea. So these are the things what the prescribing doctor need to do, and with the experience and writing more and more prescription, every doctor understands that what better they can do with their own experience to not to do any harm to their patients, and if there is anything happening to either stop that in the beginning or to reverse that complication. The blood work, including your thyroid profile, the HbA1c, serum insulin level, fasting, lipid profile, liver function, kidney function, amylase, lipase, urine protein, very, very important, and if possible, UACR, to be done in the beginning of the, before starting the medication, and if possible, to be repeated every 3 months. Ultrasound to be repeated, if possible, every 6 months. So these are the things what to be done while prescribing these medications to any patient. And when the patient asks for how long I have to take these medication, the answer is very clear. For diabetic people, there is no end limit if the patient is tolerating these medications well. But if for a non-diabetic, overweight, obese people, once you reach to the target, then definitely we will taper down the medication by the dosing, and then we stop that. Then my experiences with my patients, I'm sure I have done more than 300, more than 300. I don't have the number exactly because I've stopped counting them. I have found a phenomenal result, and I'm using this word phenomenal. Why? Because these are our personal experiences in terms of the weight management of our patients. And even in the people, in the patients whom we have stopped the medicine after achieving the target, patients have not, most of the patients have not gained the weight even after 3 to 4 months of stopping the medication. See, please understand that we have been prescribing, and I have no hesitation saying that we have been prescribing the medication even before they were launched, because people were in India, because people were in any way availing these medicines from here or there, and they were misusing the medication. So as doctors, it became our responsibility to supervise them. And with that, with the experience of more than 300 plus patients being on Ozempic or Mounjaro, I can say that the complications of, like the way I told, of one patient having the biliary stasis, and we had to remove the gallbladder. There was one episode which has other valid reasons behind that. Otherwise, other than the small acute side effects like gastritis or hyperacidity, constipation, and some patients diarrhea, which are easily manageable by the other medications like any proton pump inhibitor or H2 blocker, or the diarrhea by like something like loperamide, or constipation by fiber or a laxative. Things were easily managed, and people are able to do good and able to manage it. Now for the patients, what patient also, so this is about the doctor side. Now from the patient side, the bigger responsibility is of the patient. Now what is happening? Patient takes a prescription from the doctor, and then patient just never follows back. Like many patients don't follow back with the follow up with the doctor, and they keep on taking the medicines from using the same prescription. And in India there is no validity of the prescription. We write it, but nobody bothers about it. So when you write a prescription to somebody and write, say example, injection Mounjaro, so that prescription is valid for 4 doses, right? Because a pen contains 4 doses, but the patient will keep on going and taking the medicine from here and there, and without any supervision, uh, just just take them because they feel that, okay, A is giving us a better deal, B is giving us a better deal. Why I am going with 5 mg? My weight loss is slowed down. I take 7.5 and all. They do that. They do those mistakes, and they don't do supervision, and they land up in the complications. And the most common complications where they'll end up again is associated with either gallbladder or with the pancreas. And now these complications are piling up because of the unsupervised treatment taken by, or unsupervised medication taken by these people. So the patients have to be very clear that they need to follow with the doctor. They should never take these medicines because the next door is taking the medicine, or somebody in the family is taking the medicine, or share the same medicine with his or her, either the spouse or the sibling or whoever. They should never do that. Proper supervision, proper screening, proper follow up with the doctors is very, very important. Patients don't need to, should not get carried away by the promos which are coming on the social media, or the social media like Instagram reels, or the big advertisements happening here and there, and start these medications by themselves. This is something what patient need to understand. Patients should always follow the dietary recommendation given by their doctor. They should not make their own, those experiments. And very importantly, they should stop following those diet apps when they are on these medication, because these diet apps don't understand, the seriousness of these medications. So therefore, the role with the doctor is very, 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 very important. Needs to be away from alcohol and smoking or any other recreational drugs if the patient is using. Very important. So these are the things what a patient has to do. Patient has to understand that, it is their right, and it's the duty of the doctor to discuss these medicines with them, discuss the eligibility of these people with them, discuss the fitness, discuss the contraindication, discuss the dose. This is absolutely understood that these are the right of the patient and the duty of the doctor. But patient also has the responsibility to take care of themselves and follow the guidelines very compliantly, religiously, and I should say use the word fanatically here. I'm using the word fanatically because these medicines, if are being prescribed, should be used fanatically by the patient with all the guidelines given by the doctor. And then comes the third party. The third party is the pharmacist, the medical stores. And somehow this trend is becoming very bad where the medical stores have been given, somewhere, I don't know who gave them the right and that implied, sense of freedom that they can directly approach any patient by a WhatsApp and tell them, hey, there is this weight loss drug, and I can give it to you, and you should take it. And this is what is happening, at least in the metropolitan cities like Bombay, Delhi, I'm sure, Bangalore, Chennai, everybody, everywhere it is happening. And then people get carried away because they give them so much of, gloomy picture, and they finally take this. So medical stores today are having, primarily, it seems that it is apparent that they are having, no accountability. They don't need any prescription. They feel that they don't even need prescription of medicines like Ozempic and Mounjaro, which are actually having a warning, that they have to be used. So, so hello. Yeah, sorry. So these medicines to be used under supervision, and they just keep on selling these medicines directly to their own contacts and their own people. And this is somewhere, and they are not, even the medical stores at many places don't even have those facility to maintain the cold chain of these medicines. And there it becomes a problem that from dispensing the medicine under a prescription or on a prescription by a registered medical practitioner, medical stores start playing the role of the medical practitioner and start dispensing these medicines to these people for their own vested interest. And that should be, strictly, taken care by the authorities. And this is something what medical stores have to understand. So what are the do's for the medical stores? So medical store have the responsibility to make these medicines available in their outlet, and then to dispense this and to maintain the cold chain of these medicines, and then to dispense these medicines to their clients, because for them these people are the clients, and for us doctors these people are the patients. So to dispense these medication only and only with the valid prescription, and only the dose should be decided by the doctor and not by the medical store. So these are the small, but very, very important do's and don'ts for the medical store people. So the three parties, here in this whole obesity management, the buy these medication like Ozempic and Mounjaro, the patient himself or herself, the doctor, and the medical store or the pharmacist. They have to come in conjunction with each other and respect the boundaries of each other, and do these follow these guidelines. Then I'm very, very sure and very optimistic that these medicines can really do something very great in terms of managing this epidemic of obesity in our, not only in our country but globally. And also, when the supervised management is happening, the side effects will be less, because when the side effects start pooling up, then the medicine gets a bad name, and finally the medicines are withdrawn from the market. So we have to use them very, very, very judiciously, very carefully. And yes, it is our duty to discuss these medicines with our patients and prescribe them, whoever are eligible and fit for these medicines. And yes, let's fight with this epidemic of obesity, so that we can prevent further complications of obesity, which the world is looking towards. And I think with this, I have tried to explain the do's and don'ts of these injections, like or even the tablet in that way, the Rybelsus, the semaglutide, and the injections like Ozempic, Mounjaro, Wegovy, or your peak is there. Now, one more thing I want to add up over here, and then I will be done. Then in next 2 months, maybe by March, the Ozempic will be losing its patent, and many more brands will come in the market. Many more companies are ready. So maybe in next 5 to 6 months, we are expecting a lot of brands, to a lot of players to come. So the cost will also go down. Once the cost goes down, then a lot of people will be taking these medications. So we have to, it is then it becomes the responsibility of the authorities and the doctors and the medical stores to make sure that the people who are taking, the patients who are taking these medications, are supervised well. This is very, very important. So, with more availability and cost coming down, our responsibility will go up. And then one more good news is that Wegovy 24 milligram oral tablet is already being approved and already is there or launched in the US. So we are expecting that that would be there in India maybe in next maybe 5 to 6 months. So once that oral medication other than Rybelsus is also there in the market, then more and more people will be using these molecules. So these do's and don'ts should be very, very clearly discussed with the doctors, discussed with the patients, discussed with the medical stores. And with this, we can make these medications more favorable to the patients, and the pros and cons will be more towards the pro rather than the con side. And we will be able to, if not win the epidemic of obesity, at least control this epidemic, and maybe more and more molecules coming in, and the people are getting more conscious about their own lifestyles and all. I'm very, very sure and very hopeful that in next 15 to next decade, we will be in a better position in terms of the obesity epidemic. And with this, I would like to conclude my talk, and I hope I'm able to answer the unanswered questions with my talk. If there is any question, please feel free to ask. Dr. Natesh, I'm done.
Hi, sir.
Yeah,
So very good insights you have given about how the drug has evolved from the past, from the all the gray market, the actual scenario, and
yeah,
you actually very well segregated from whom is the drug is coming and what is the role of the pharmacist. So
yeah,
I'll explain. Uh, we have few questions in the chat box. I'll be asking if
please.
the audience have to interact. Please unmute and you can ask questions. Of course, the first question you have asked, I mean, you answered already. Can non-diabetic people take the medicine to reduce weight?
Yeah,
Yeah,
yes,
that is one.
that is approved for the non-diabetic obesity people.
And Dr. Ramaraj is asking, is it necessary to see lipase and amylase after 3 months
Yes.
of initiation of Mounjaro?
Yes, we should, and we have seen. It is my own. Again, I'm not an authority, but with the use with more than 300 plus, so definitely I have a very strong data of that. Amylase lipase of, of the patient in 3 months should be done, because uh, we know that these medicines can cause the fatty medicines themselves can cause the fatty infiltration of the pancreas, and we have to be careful in that. So better to do amylase lipase because we cannot simply go and keep on doing the ultrasound of the patient. And there is one more thing I want to mention over here, that there is something called as the cholelithiasis in weight loss also. So
Mm.
people who lose weight and who are very highly restricted in their diet, they are also having a high tendency to develop the gallstone. So sometimes very small sludge can just pass on to the pancreas and cause a pancreatitis, and may not be a very evident symptom. And the patient when complains that they are having the pain in abdomen or anything, many times we consider we we just miss that, considering to be a side effect of the drug. So it's better to do amylase lipase every 3 months.
I have one more question because I mean, it's a known person had history of cholelithiasis, managed without surgery, but this was around 15 years back. The patient is now 115 kg, height is around 5'2", diabetic patient. OSA is that the female patient, she's on CPAP, age is 62.
Yep. I'm sorry, some calls are.
No problem. No
Yeah,
problems.
yeah. Please. Yeah.
I mean, no history of any diabetic retinopathy. HbA1c is 8.6. Any risk of this patient going for a frank chole, cholecystitis if you put it
So
on Ozempic or
no,
Mounjaro?
no. So the patient had cholelithiasis, right?
History of
Before
yeah, he was
15 years
on
back.
the drug UDC
So the answer is very clear. If a patient had a history of cholelithiasis and if the gallbladder is not removed,
15 years back. 15 years back.
it was removed.
No. It is not removed. But the issue was
So
15 years back.
So I got it. Even if there's a history
Pre-menopause.
of even if there's a history of cholelithiasis 15 years back and the gallbladder is intact and the cholecystectomy is not done, then that patient indeed is at the risk of developing gallstones, irrespective of whether we are putting the patient on medication on these medication or not. And in that group of patient, it is very important that we do the ultrasound before starting these, and we have to more vigilant in these people. Maybe we will do ultrasound more frequently than any other patient. These people are indeed at a higher risk of developing gallstones,
But no
irrespective.
contraindication, but a high risk.
It's not a, so the history, and if the current ultrasound is not showing any gallstone, definitely it's not an absolute contraindication, but we have to be cautious.
So no fat infiltration of the pancreas and no current risk of gallstones. We can go ahead.
Absolutely. We can go ahead and we have to be just a bit more vigilant, but we have to go ahead. See, today we have to see more reason of giving, prescribing rather than denying. We have to be very calculatedly because we are fighting with a very big epidemic of obesity now.
So semaglutide versus tirzepatide, which is your call, sir. So
Both.
how will you segregate which patient to what to give?
Both. So a diabetic patient coming, definitely Tirzepatide becomes my first choice. And for any non-diabetic overweight individual, that completely depends upon person to person. And it is something like nimesulide versus ibuprofen.
Any impact of GIP when you say that I'm going to choose diabeticity for Mounjaro, I mean
So
for tirzepatide?
so anyone who is coming with diabetes with obesity, definitely my first choice would be Tirzepatide, Mounjaro, for sure.
Yeah. So what the role of this GIP in the patients? GIP substitutions there, no, in like tirzepatide. Anything has to do with the diabeticity?
See,
Diabetes.
Mounjaro okay, Tirzepatide has a better insunotropic effect compared to the semaglutide, and that's the where it has one edge when it comes to though it was Ozempic or it was semaglutide which got the first approval for the
Yes.
diabetes obesity.
And last one, was a big penis and was a big vulva. Want to hear from you, like, have you faced this in your practice?
No,
We need this.
not at all. I can tell you this, except for the thing what I read, what we see on the reels of
Hmm.
certain, some celebrity, quote
Yeah.
unquote. Otherwise, not at all. And even in that particular individual about whom it is being, said a lot. I will not take the name, and we should not. Whether it is because of Ozempic or because something else, who knows? No, not at all. It's the other way
So
around.
3 patients, no was a big penis and no
40,
was a big vulva.
45, 40, 45-year women got pregnant.
Okay.
45-year accidental pregnancy. So that is what we are seeing. I'm not saying it's a treatment of fertility, but I'm saying accidental pregnancy. So what sort of the confidence and the thing, and the self-image confidence people are getting.
Fantastic, sir. So, any other questions from the audience? Audience is there. Next speaker is almost finishing a procedure. Okay, just
So if there is no other question left, may I take your permission to leave?
please, sir. Thank you so much for joining, sir.
Thank you so very much, Natesh ji, and thanks a lot, the audience, and I hope I was in position to answer whatever the unanswered questions. And take very good care of yourself and everybody. Jai
Thank you so
Hind.
much, sir.
Bye
Excellent, sir.
bye.
Thanks so much.